break. We are going to carry on, and let me pass the floor now to Marion MAIN, who is going to talk about physiotherapy management for children with CMT and peripheral neuropathies. Marion, the floor is yours.
Thank you to Flora for inviting me to speak. Most of what I will say is related to children because it is a children's hospital, so some of it is relevant to adults as well. We have over 200 children that we see at Great Ormond Street with peripheral neuropathies, including Charcot-Marie-Tooth, CIDP, and some other disorders. And they are a group of children who are generally badly managed because the condition seems to be mild, but affects a lot more than people think. So it is the most common inherited neurological disorder in the world. In the UK, we have around 20 to 25,000 people affected by CMT. And the research into exercise and physiotherapy is mostly directed at adults. There is very little has been directed at therapy in terms of physical therapies in children. So these are the common forms that you will find. Now, this website is one of the most important neuromuscular websites you could ever see. If you put into Google neuromuscular homepage, you will come up with everything you virtually ever wanted to know about neuromuscular disorders, and this will tell you of all the different types, whether they are axonal, whether they are related to other conditions. There is so much on this website that is useful that it is a brilliant place to start. So we know that the problems generally, although there are clinical practice guidelines that are published from the Australians, they are not strictly relevant internationally. There is still a lack of consensus on management. There is a lack of understanding of the different forms of CMT. But what is important with CMT1A, the most common form of CMT, is there is a parent affected, and you really need to look at the parent, find out what difficulties the parent had, because often these are replicated in the children. So our priorities as physiotherapists are manage the foot posture, weakness, pain, and deformity. Importantly, to manage hand problems, because many of the children do not recognize their own hand difficulties until you ask them the right questions. And while they are called peripheral neuropathies, they affect much more than just the hands and feet. So physiotherapy must start with assessment. We look at range of motion. We look at power, and we are probably the only unit in the UK that regularly measures the children's power, which has missed off all the CMT scales. I met a 14-year-old girl 2 weeks ago who had never had her power measured and who showed quite marked hip weakness, which had never been noticed and was a cause of much of her difficulty. We obviously look at their walking, their function in terms of activities of daily living. We may look at their sensation. Assessments include time tests. The foot posture index is used in some places, but we do not use it. And in fact, the person who developed it has admitted that it has limitations. We look at hand function, including grip strength. We want to know the orthoses and the shoes. The shoes are important. Pain and fatigue is a feature in many of the children. And there are quality of life and patient outcome measures that may be used. Now, fatigue scales and pain scales are often difficult for children to answer effectively. We know that many children who use pain scales will often say the pain is greater and will point to 9 or 10, which is thought to be unreasonable. And fatigue is also a concept they don't always understand. We assess to establish a baseline when we first meet a child, and obviously to look at change. We need to know how the things that we are assessing affects their everyday management, and this is what it is all about. We assess every time they move. We are looking all the time at how they move, the speed they move, the quality of what they do, even taking their clothes off when we ask them to. Usually at Great Ormond Street, we will see the children every 12 to 18 months, but we have an open door policy where parents can ring us and ask to be reviewed if there is a problem. And while many of the children are seen to have good function, this often means they are badly managed in the community and often do not get local therapy input. We're looking for patterns, including the usual difficulties we know we will see in the types of CMT, of joint contractures and weakness. Again, we will ask the parents their difficulties because we know that patellar dislocation, hip dysplasia, kyphosis, if a parent has these, then the child is more likely to have them. And there is nothing to stop any child with any disorder having two disorders. Because you have CMT or anything else, you may have something else going on, and we have to accept that. We also must accept if the mum or father has CMT and we are asking them to do exercises at home, is that possible? Can they actually manage to help their child do the exercises you're asking them to do? This is really important. So the joint ranges that we look at are many. We need to know what is normal. We need to know what to expect. We're looking at virtually all joints, possibly not the shoulders. We also measure something called Q angle. And the reason we measure that is because if it is greater than 20 degrees, the child is at greater risk of patellar dislocation. We want to look at long finger flexors. But unless you look correctly with the wrist extended, you will not see long finger flexor tightness. So you need to know how to measure as well as what to measure. Age can affect the assessment, but do not make age an excuse. You can watch what the child is doing. You can see how they play. You can see whether you give them small items like Lego, do they have difficulty with it with their hands? So there is no excuse for saying a child is too young to be assessed. Also importantly, when you're assessing a small child or even an older child, you need to know when they are fatigued, when to stop, when they are unhappy with the assessment. Sometimes they find it very negative to be told what their difficulties are. And I'm sure the adults in the room appreciate this problem, that when you're a 14-year-old teenage girl, you do not want to know what you can't do. You do not want somebody talking about your funny feet, that you cannot get into sexy shoes. So you need to appreciate the emotional difficulties that go with being assessed. We look at fatigue and activity monitoring, but mostly in the research situation. We have time tests. We can do the 6-minute walk test, but we only do this in research. We have this very beautiful 6-minute walk test track, built into one of the corridors at Great Ormond Street, but we only use it for research. But there are many, many validated time tests that you can use. This is my favorite position for looking at foot posture, and all my CMTs will be asked to get into this position so I can look at what is happening at the bottom of their feet. There are foot assessments, we don't use them. We feel as experienced physiotherapists, we can see what is going on. And this is one way that we can look at gait and feet. You can, if you do not have expensive gait equipment, paint and paper will tell you an incredible amount. This child did not have long toenails. She had foot drop, so scraped her toes along as she walked. We call this a Yeti foot, and you may think it does not need treatment. But actually, this very narrow heel will slide around in a shoe, so we will give these children heel cups to help, and it makes a big difference. Strangely, I have only seen Yeti feet in boys. But you can see sources of pain, you can see a very tight TA, and you can see how the weight bearing is going, even from this simple method. And interestingly, it is assumed that children with cavus feet will have TA tightness, but many cavus feet, the hind foot is pulled down by the cavus deformity, and the TA is actually lengthened. So you may not need to be doing TA stretches or have surgery to the TA to correct a cavus foot. These are all the strange sort of feet we see, both pre and post-surgery. We test hand function, and many people will test gross grip. But actually, if you think about it, this is the grip you use least in a day. It is rare to be using a power grip, so we tend to use pinch and what we call key, thumb grip, we test as well. We also have manual dexterity, which we test for normal. We don't really use the 9-hole peg test. It was developed for ataxia and only really works for the children with sensory loss. We need to know about activities of daily living. What things do the children have difficulty with? This is so important. We need to look at the exercise they're doing, the stretches they're doing, the orthotics they're wearing, their ADL function, their spine, because this is often forgotten, and pain and fatigue. Now, while CMT1A is the most common form, CMT2 is the most severe form we see in children, and the children really do suffer. We like symmetrical sports. We avoid. We like tap dancing, Bhangra dancing, and Irish dancing because they like making a noise with their heels, not their toes. We love swimming, but there's a big problem with swimming, is that many of the children have difficulty walking around the edge of a pool in bare feet. So that we have to think about all these difficulties they will encounter. Yoga or Pilates is great for the teenage children. Play is exercise. Get in the kitchen, make bread, make pizza, do activity, maintain your hand strength. You cannot improve the strength of a muscle that has no nerve supply, but you can try and maintain strength as long as possible. People forget that musical instruments can be good exercise. Last week, I saw a young man who had lost the ability to supinate his left hand, so could no longer play the guitar. he was considering surgery. Nobody had suggested restringing his guitar to his other hand and playing as Paul McCartney did so that he could continue to play, which was a revelation to him. These are the exercises we avoid for all neuromuscular conditions. Very asymmetrical. You will only ever stand on one foot and push with the other. You may or may not play rugby here. We don't like it. We're not too keen on ballet or gymnastics, and this is a total no-no. It's dangerous. It's not a game. People have trampolines as a game, and they are dangerous. The biggest cause of childhood injury in England last year was trampolines. We don't always stretch hind feet and ankles if they don't need it, and sometimes stretches are not effective. If your hind foot turns inwards, you cannot effectively stretch your Achilles tendon. You can only stretch your Achilles tendon with your hind foot in neutral. And this is really important because you will do more damage than good if you are stretching a foot with an inverted hind foot. We do plantar fascia stretch. It's not madly effective, but we use a cold water bottle to make it more comfortable, particularly with plantar fascia pain, and we get the children to roll the bottle. This is a nice one for adults too. We do not like putting the children on a step because you can make the plantar fascia problems worse. We always make sure the heel is on the floor and the foot is upwards. We suggest every family gets Harry Potter. Why? Because, not to read, but because the first book is very small and the last book is very wide, so they have a graduation of steps they can use as their feet get bigger. We do serially cast. We are very careful, and again, unless the hind foot can be brought to neutral, there is no point in casting. The child may as well go straight to surgery. If needed, we will tape the hind foot into neutral before we cast to make a more effective casting. Surgery is important, but you need a surgeon who is listening. You then need an orthotist who knows what they are doing. The best surgery in the world will be ruined by poor post-op management. If you do not know what to do with the feet after the surgery, then the surgery can be a waste of time. Surgery is not a cure. This is so important. And in CMT with a deteriorating condition, the younger you do surgery, the more likely it is you will need it again. But in CMT 1A, up to 50% of the children will need foot surgery while they are still children. Orthoses are really important. And the most important person in our team for CMT is our orthotist. And thankfully, they do know what they're doing. We don't use hinged AFOs in CMT. The children don't like them. This is for foot drop. This is the most common but the most expensive orthosis. This is a carbon fiber offset leaf spring AFO. Don't remember that. Leaf spring AFOs for foot drop, fixed AFOs. We use this for hind foot difficulties and trilocks for instability. This is a complete waste of time, as is this. This is reasonable, but this is the best form of orthosis because it is controlling the hind foot. And if you don't control the hind foot, then you are not really solving the problem. This was a problem caused when a child was told she would get used to her splints. No child should ever wear a painful orthosis. It is not acceptable. We do not get used to our shoes when we buy them, although there are some ladies who do. But generally, it should fit and be comfortable and do the job from the beginning. I notice you have these on show here. We like these. We like these Nike ones that open at the back. Generally, we prefer trainers with a good orthosis, although I know some of the girls would prefer this. People forget that kyphosis is quite common in CMT. Poor spinal posture, back pain is a problem. Pain can be a big problem in CMT. Hip pain, we always ask about because people forget that there is a high prevalence of hip dysplasia, knee dislocation, pressure areas. Neurogenic pain obviously can be treated with medication, and more importantly, fatigue, which we can manage. We need to think about what's happening to these children when they go to adult services, make sure their orthotics are right, that they do have a good program in place. These are the take-home messages. It's common but often undermanaged and needs an experienced team to actually manage it properly. Pain, foot deformity, hand functions are the main problems, but not the only problems. Knees, hips, trunks can all be affected. Fatigue, we need to manage this in school. If you cannot write enough, if you cannot write without pain, then you will never perform well in an exam, and the schools need to appreciate this. Foot surgery is important, but the management afterwards is equally important, and orthotics must be comfortable and do the job. Children are not inherently lazy. Teenagers are maybe a different problem. Teenage girls get over it. Teenage boys possibly get over it, but most of them are teenage until they're 80. Children are not inherently lazy. If they appear lazy, it's because they have tried and failed, because they are demotivated. If you find something positive, they are not lazy. But lazy and batteries don't always go together. You can't manage CMT without a team around you, and the team is what it's all about at Great Ormond Street. But most importantly, we learn from the parents and the children. So thank you to all parents and children with CMT. Thank you.
Thank you very much.